So I'm Maura Ryan. I'm one of the neuroradiologists here, and I'm just going to talk for about half an hour about white matter abnormalities in children, simplified. And we'll put a question mark there because I think anybody who's read any of these studies knows that it's not a simple topic. It's not a simple process. Hopefully, though, we can show a few simple key points that act as a framework so you can approach these in a little bit more of a confident way instead of sheer panic. Okay, so outline, I'll talk about normal myelination patterns. Obviously, I think it's very important if you're going to tell something that's abnormal, you have to know what normal is, and that's not always easy in the really young kids. Then we'll talk a little bit about definitions and terminology, which can be kind of confusing in this area. And then I want to do a case-based walk through some of white matter abnormalities, and I'll concentrate on either entities that are a little bit more common or characteristic by imaging. So the first question is, what is normal? And here I have 4 different patients at different ages from term to a year of age. 2 of these patients are normal and 2 of them are not. I think one of them is pretty easy to pick out, maybe the other one isn't, and we'll return to this slide about halfway through after we go through some cases. Okay. So one of the problems with this is that every couple of months you really need to adjust yourself to what a new normal is. Myelination is a process that progresses rapidly in the first year of life. So every couple of months, there's a new normal, something maybe we're quite used to in the 2020 year, but certainly can be difficult for imagers. So there are various atlases and charts out there. This is adapted from a former colleague of mine, now at University of Chicago, Dr. Karina Yang. But there are plenty of these out there, and there are also imaging atlases. So I think it's helpful if you're going to read any pediatric patients, just have access to one of those that you like so you can refer to it. Another tip I will sometimes do is if you come across a normal patient when you are reading studies or something, just put it in a folder so that later on when you're thinking, oh, is this what a 3-month-old is supposed to look like, you can kind of pull that up. And I will show some very simplified version of this chart in a little bit. But I think also that there are key fundamental concepts and patterns to keep in mind about myelination that are helpful just to give you kind of a framework. And the first is the T1 and T2 changes. So T1 really increases as a patient myelinates, and that's related to fat in the myelin sheath. So fat is a component of myelin, so as you myelinate, your T1 will increase, and then the T2 signal will decrease, and that's associated with decreased water content. So as the axons mature and they become a tighter bundle, there's less water there. So T1 increases and T2 decreases. This doesn't happen at the same time. It follows the same pattern, though. The T1 images will happen first, and we generally say they look about adult-like with a few caveats by 12 months of age. T2, it's usually about 2 years. So here, this is a normal 12-month-old. On T1, we can see the normal T1 hyperintense myelin pretty much throughout the brain. On T2, again, a similar pattern, but a little not quite as far along. There are still some areas here that are T2 hyperintense. So T1 before T2. The second kind of overarching principle is that there are gradients of myelination, and these are really central to peripheral, so you myelinate centrally first and then extend out peripherally, posterior to anterior, so posterior first and then anterior, and then inferior to superior. So here on T1 and T2, again, T1 looks a little bit slower than the T1s, right? T1 here we have myelination through a significant portion of the brain. T2, it's really just more central, nothing really peripheral here. On the T1 images, you can see there's more myelination posteriorly, pretty gray and fuzzy still anteriorly. So those are your basic gradients. The other thing I think is helpful is just keep a few, you can't really memorize an entire chart like that, especially if you don't do this every day, but you can keep a few sort of landmarks that act as linchpins that you can kind of build around. So I like to remember what term birth patients look like, and really on T1 and T2 it's very similar. It's just that there's a little bit of more apparent myelination on the T1s. It's really the dorsal brainstem, the posterior limb of the internal capsule, not complete, but you should see some there. Dorsal ventrolateral thalamus, some in the globus pallidus, and also plus or minus perirolandic areas. Certainly at term you can usually see a little bit there. Then if we look at, say, the splenium and genu of the corpus callosum, T1, I usually remember around 3 to 4 months for the splenium and about 6 months for the genu. T2, again, a little bit further along, 6 months and 8 months. And then the interlumen of the intracapsule is actually a little bit variable. Again, T1 is going to be before T2. Usually you will see that before 6 months on T1 and certainly before a year on T2. So if we just look here at some normal patients, T1s on the top, T2s on the bottom, you can again see term, posterior limb of the internal capsules, this T1 hyperintense myelination. Not a whole lot else going on there. If we look at 3 months, that has extended, maybe get a little bit into the anterior limb, a little bit in the splenia of the corpus callosum. 6 months, significantly progressed. We have corpus callosum, splenium, genu centrally, but still some gray fuzziness here in the periphery, particularly ventrally, following those gradients. 12 months looks pretty close to an adult normal looking patient. T2, very similar pattern, but again lagging behind. So if we look at the term, there's a little dot here in the posterior limb of the internal capsule, get a little bit more, again posterior gradient, less anteriorly, the central gradient less in the subcortical regions. So that's kind of normal. Few other things to remember about myelination. T2 flare can be difficult in young kids, particularly here at the about maybe 6 to 18 months or so. When you're intermediately myelinated, it looks very patchy and very irregular. So this is a sequence that we rely on very much in neuroimaging, but it's less helpful in younger unmyelinated patients. Another caveat are terminal zones of myelination. So these are areas that can normally be visible into later childhood. We say they're usually myelinated by 2 years of age, but these really can extend quite a bit later. They have typical locations. One is periventricular, so posterior and superior to the trigone, we can kind of see here. And then the other is subcortical, particularly in the frontal and temporal or subinsular regions. And these usually look a little bit brush-like. In fact, sometimes they may be associated with some increased perivascular spaces. These really should be symmetric, and in these common locations, it can be sometimes difficult to tell if there is pathology underneath or not. And sometimes we just have to follow these patients and see if something develops. So when we talk about white matter abnormalities, there's 2 major buckets. There's the heritable white matter disorders, the leukodystrophies and leukodystrophy-like processes. And that's what I'm going to talk about most today, because I think this is really what most people think about when they think about white matter abnormalities. And certainly it's something that gives us a lot of anxiety, I think, in radiology, trying to figure out what's going on. So I'll concentrate on that. But there is also, this large basket of acquired white matter disorders from secondary insults. And sometimes it can be difficult to distinguish between these two. So we're going to concentrate on the heritable white matter disorders first of all. So what exactly is a leukodystrophy? Well, this term has actually been, I think, changed a few times. And there is a global leukodystrophy initiative that actually got together around 2015 and tried to propose a more standardized and refined classification of leukodystrophies. And just to give one caveat as well, that these are not just diseases that affect the oligodendrocytes, which are the cells that actually make the myelin, but really there are a lot of complicated interactions in myelination. So you can have leukodystrophies that are predominantly affecting astrocytes, axons, microglia, even the blood vessels. But they are largely progressive, and most often they're in pediatric onset. So what was characterized as a leukodystrophy, they asked a panel of experts, and they came up, this is in 2015, and I think this is expanding really as we understand more and more about these diseases and come up with better genetic testing. But at this point, they characterized more than 30 entities that would be considered leukodystrophies. And I'll also just point out on the right-hand side here, these were the percent of respondents classifying these particular entities as leukodystrophies on the first survey. They eventually all agreed, but you can see even on the first pass, amongst a panel of experts that deals with these kind of diseases, there was a little bit of confusion. And they also separated out true leukodystrophies from genetic leukoencephalopathies. So what are these? These are also abnormalities that have white matter changes, but it's not predominantly white matter. That there is either a gray matter component or a multisystemic component that overshadows the white matter changes. And this includes a lot of errors of inborn metabolism, although there are some metabolic abnormalities that are still considered leukodystrophies. So I think it's a little bit of a confusing term, but that's basically what we're talking about is heritable disorders that have a predominant white matter feature, really the leukodystrophies. So lots of these and more coming as we get more and more understanding of the genetics. So when we're talking about leukodystrophies, and we're really just going to concentrate on that because obviously it's a very broad topic, there's again two major buckets. There's the hypomyelinating leukodystrophies, and then there's everything else. So hypomyelinating, the myelin is absent or arrested, but it's intrinsically normal. And in everything else, the myelin itself is really abnormal. Have to be careful about the definition of hypomyelination because I think we sometimes overuse this. It really is persistent T2 signaling regions that should be myelinated by age. The T1 changes can sometimes be a little less apparent than the T2 changes, so it may only be mildly hypointense or even isointense on T1. And we really want to see this as an abnormal pattern that is unchanged on 2 MRIs at least 6 months apart in a child more than 1 year. So that's a little complicated, but what it really is showing is that this is a relatively static process, and that's to distinguish it from delayed myelination, where we also have areas of T2 hyperintensity that are abnormal for the chronologic age, but if you follow those patients, they eventually do myelinate, and we can see delayed myelination in a variety of settings. Prematurity, thyroid dysfunction is a big one, but it really is distinctly different from the true hypomyelination of leukodystrophy. So just know that hypomyelination requires you to follow the patient with subsequent MR before you can confidently characterize that. Okay, so let's look at cases now. And as we go through these, keep an eye on the age and the gender and the clinical symptoms, because I think there are patterns in the clinical presentation as well as imaging that can really aid in diagnosing these patients. All right, so this is a 2-year-old boy with nystagmus and gait abnormality, 2 years and 3.5 years. Does not look like a normal myelination pattern, right? 2 years of age, even on T2, you should be almost completely myelinated, and here we don't see a whole lot, maybe a little bit in the corpus callosum, not really at the level of the internal capsule here, so you can't really see that, but nothing else really here looks myelinated. It's all really T2 hyperintense. And if we look at 3.5 years, hasn't really progressed. So we have 2 MRs that are basically the same, more than 6 months apart, and a kid that's over 1 year of age. So that really is hypomyelination. If we scoot forward to 6 years of age, there might have been a little bit of progression. It's a little hard to tell because I didn't give quite exactly the same slice orientation, but still very abnormal for a 6-year-old, right? There's really no myelination in many areas here. Again, if we look on T1, it's less conspicuous. There is decreased T1 signal from what you would expect in a normal patient, but it's a little grayer than it should be, but much less characteristic. So very classic appearance of a true hypomyelinating disorder. And this is Palazius-Merzbacher, which is basically the prototypical hypomyelinating disorder. It's relatively rare. It's related to an abnormality in a protein that's a main structural component of myelin and results in oligodendrocyte apoptosis. You don't really lay down the myelin. It is X-linked in its classic form, so do think about this with male patients, although there is a subtype that is autosomal as well. Imaging-wise, marked hypomyelination is really the salient feature of these patients. So they may be 3 years of age, 5 years of age, and they basically look like a neonate. There might be a little bit in the posterior limb of the internal capsule, a little bit in the corpus callosum, but otherwise look very much like a newborn patient. They typically will have a relatively normal brain volume, not a whole lot of volume loss in comparison to some of the entities we're going to look at next. They often will present with nystagmus, tone abnormalities, developmental delay, or regression, also very common presenting features for a lot of the leukodystrophies. All right, so this is a 2-year-old girl with decreased language use and gait abnormality. What do we have here? Well, this is a little bit of a different pattern. A little bit of an older patient than the first one I showed, but clearly abnormal white matter. bilateral, very symmetric, and has a central predominance, right? It's really the periventricular regions. You can actually see normal subcortical myelination here on the T2s, right? So this is a central predominant pattern. Not really enhancement, but it does have this kind of weird stripy pattern where it looks like maybe there's some preserved myelin in certain areas. So this is a very typical appearance of metachromatic leukodystrophy. So this is the most common leukodystrophy that we will encounter. It's autosomal recessive. There are infantile, juvenile, and adult forms. The late infantile form is the most common, usually around 12 to 18 months or so. It's a lysosomal storage disorder with aryl sulfatase A deficiency, and results in confluent signal changes. The pattern of these is usually predominantly central, so it's a centripetal pattern. That's one of the patterns we're going to see repeated in several of these entities, has characteristic sparing of the subcortical white matter, and these patients will often present with gait abnormalities, loss of milestones, again, developmental regression, particularly losing milestones, is a very typical appearance or clinical appearance of leukodystrophy. And then the last sort of very characteristic imaging finding that these patients have what are called either tigroid or leopard skin abnormalities, and that's these areas of myelin that are preserved along the perivenual spaces. So if you think about where perivascular spaces are, or where you see MS plaques along the perforating venules, you get some preservation of myelin. So depending on which way you cut it, it can look either like a tiger or a leopard. So this isn't necessarily pathognomonic for this, but it is a very common feature and a useful one as an imaging pattern. Okay, so 7-year-old male with ataxia and mumbled speech. What do we have here? Well, also a centripetal pattern, right? It's predominantly central, but we still have preservation of some of these subcortical areas of myelination. Symmetric. This one has a very striking posterior predominance, right? Peritrigonal, splenia of the corpus callosum. This actually does have a little bit of contrast along the outer margins. This is a case of adrenal leukodystrophy. So this is probably your second most common leukodystrophy. It's relatively common considering these are all really sort of uncommon disorders. It is also X-linked. It's most common in childhood, although there are some adult forms that have been described. This is a peroxisomal disorder, so you get an accumulation of long-chain fatty acids that have an inflammatory demyelination associated with it. Sorry. So the imaging appearance of these is, again, confluent central signal changes, has a much more posterior predominance than metachromatic leukodystrophy, which sometimes can be a little bit posterior, but not this striking. And enhancement is common. We don't need to give contrast or see enhancement to diagnose these, but if you do give it, you can see what's called Schomburg zones, which are areas of enhancing active demyelination with inflammation, and usually outside of that, there are areas of demyelination without significant inflammation. Sometimes deep to that, more centrally, you can see some necrosis. Don't have that here, but you do see these kind of different zones of abnormality. And these patients, again, as with many leukodystrophies, impairment in motor and cognitive function. They also can have vision loss. Again, with the posterior predominance, can affect some of the optic tracts. This is a 5-week-old female with seizures, delay, and paresis. It's a bit of an older scan, so it's not maybe quite as nice, but clearly there's an abnormality of the white matter here. It looks more central, at least posteriorly, looks like, again, more of a centripetal pattern. Has a striking anterior predominance and actually looks pretty swollen here, right? A lot of these gyri look expanded. This is a patient with Alexander's disease. This is a sporadic astrocytopathy where you have some accumulation of Rosenthal fibers and eosinophilic granular bodies. These patients, by imaging, present with confluent symmetric white matter changes, as with a lot of these leukodystrophies, has a very significant frontal predominance in many patients. These also generally will progress relatively quickly to cystic encephalomalacia. You can see on the, this is actually quite a few years later, but still you can see that there's significant cystic change on follow-up imaging. These patients have macrocephaly. which can be another distinguishing clinical feature. There's a subset of these patients that will have of leukodystrophies that have macrocephaly, which can be an important distinguishing feature for us as well. They often will have rapid neurologic deterioration, seizures, spasticity, and obviously developmental regression. Okay. So this is a 3-month-old girl with macrocephaly. What do we see here? Well, it's a little difficult at 3 months. Is this normal or is this abnormal? So this is an instance, I think, where it's helpful to just pick up someone that you know is normal and compare them. Well, if we look at the normal patient, there's definitely more myelination of the posterior limbs of the internal capsules. There's a little bit of perirolandic myelination here, which we don't see in this patient. Now, it's possible, is this just delayed myelination? Were they a premature infant? Well, if we follow her up a little bit, excuse me again, at 9 months, now we can see that there's really more significant white matter abnormality. So not only is there no myelination in areas that we would expect myelination at this point, but the T2 signal is really too bright. So you can kind of see the normal unmyelinated white matter is a little bit grayer. This is really too bright, much brighter than it was previously. Again, there looks like there is some swelling at 9 months here with some gyral expansion here, some edema. If we look forward to 3 years of age, still no normal myelin, a little bit of edema still ventrally, and we've started to develop some of these tiny cystic changes. So this is a patient with megalencephalic leukoencephalopathy with subcortical cysts. This is a relatively recently diagnosed leukodystrophy by Dr. Vandernap, who is probably the premier investigator in leukodystrophies from a radiology standpoint. It's an autosomal recessive disorder, usually presents at about the first year of age, has diffuse confluent white matter changes. And in contrast to the ones that I showed earlier, this really has more of a centrifugal pattern with early subcortical involvement. So we can really see here, none of these areas of subcortical white matter look normal. These patients generally will have swelling, and if you follow them, they will develop, as the name implies, cystic changes. These patients do have macrocephaly, similar to the Alexander patients. They have motor delay, cognitive changes, and seizures are fairly common. Here we have an 18-month-old girl with macrocephaly, again, delay, abnormal tone, and I had to lift this image from the literature because I don't really have a good case from our hospital, but I think it is very, again, illustrative of some of these patterns. So again, this really looks like one of those peripheral involvement patterns where if you look here, there's actually a little myelination of the perirolandic regions centrally, but nothing else really peripherally. Maybe there's a little bit in the internal capsules. In addition to all of the white matter changes, there's obviously thalamic involvement, but it is still predominantly a white matter process. This is the only MR spectroscopy I'm going to show because I think that's generally a little bit more advanced than I'd like for some of the residents, but this is so characteristic of this disease, I'm going to put it in here. And this is Canavan's disease, which is autosomal recessive. Again, they can present at different ages. This is an ASA deficiency, so it leads to the accumulation of NAA, and NAA is neurotoxic, so it leads to vacuolization or spongy degeneration of the white matter. These patients have macrocephaly, can have hypotonia, loss of milestones, tends to be relatively rapidly progressive. And because it's an abnormality in the enzyme that breaks down NAA, on MR spectroscopy, one of the really pathognomonic features of this is that you have significantly elevated NAA levels in your spectra. So it's the only leukodystrophy that we will really see that in. All right, so let's just look at some of the ones that we looked at because otherwise it kind of seems like a catalog of ships if you don't really have a nice framework to put that in. So here we have Palazius-Merzbacher. So this is the prototypical hypomyelinating disorders. The patient ages. They still kind of look like a young infant. Then we have leukodystrophy with subcortical cysts and Canavan's disease. Oh, I think it cut off something there. So megalencephalic leukodystrophy with subcortical cysts and Canavan's disease. So these are both patients that have macrocephaly, and they have more of that peripheral pattern where the subcortical white matter has relatively early involvement. They also generally both look like they have edema early in their disease process, so it looks swollen. Alexander's disease also has some of that swollen appearance to it and has macrocephaly, but the ones on the bottom here have more of a central predominant pattern. So we have Alexander's metachromatic and adrenoleukodystrophy, all of whom have central predominant changes with subcortical sparing. Alexander's more frontal, adrenoleukodystrophy more posterior. Metachromatic doesn't really have the same anterior to posterior gradient, but it does have these snazzy little areas of perivenular preservation that give you those stripy appearance. Okay. So let's go back to that. Is it normal here? Show you these four again. And two of these are normal. It's these two guys. They're normal. The first one, I think we've seen that a few times, Alexander's disease, frontal predominance, symmetric, predominantly central involvement. And this patient at 4 months, we really should see a little bit more myelination than we see here. There's nothing in the posterior limbs of the internal capsules, maybe just a smidge along the optic radiations, if that. And this is, again, a hypomyelinating disorder, Palazius-Merzbacher. Okay, so that's the first part. And then just briefly at the end here, I think I have a few more minutes, just to talk about acquired white matter disorders. So injury, infection, inflammation, acquired demyelination, toxic metabolic things. There's a whole bunch of things, as you know, that kind of affect white matter. And I think that sometimes this is a really important distinction to make between acquired and heritable. If you suspect that there is a leukodystrophy and a heritable white matter disorder, there are genetic panels that can be run, and these are becoming more comprehensive and more affordable all the time, but you really have to know to kind of look for that. So I think this is an important distinguisher to make as a radiologist. So is it a leukodystrophy? Here are 4 patients. I can tell you that one of these has a leukodystrophy. The other 3 do not. It's a little unfair because I'm only giving you one picture and I'm not giving you any clinical information, but take a look, see if you can figure out which one is the leukodystrophy, and then we'll return to that in just a few minutes. So here we have a 3-year-old boy with developmental delay, and we do have white matter changes, a little bit posterior predominant, symmetric, fairly confluent, but there are some other features here that we really haven't seen in the other leukodystrophies, and it's really a white matter volume loss here, and a particular deep white matter volume loss that is quite striking. So we get some squaring of the ventricular contours, and if you look at these sulci, look at how close that sulcus is to the margin of the ventricular atrium. So there's really no white matter volume there at all. And this is a very typical look for sequela of previous perinatal injury, which is characterized, I think, for me, predominantly by the deep white matter volume loss. There is usually associated gliosis, although that can be variable depending on how premature or not the patient is when the insult occurs. Typically, you will have, though, this really significant white matter volume loss, squaring of the lateral ventricles. The corpus callosum, again, showing that central white matter volume loss will be thin. Here's a normal age-matched control. Often there is a correlating birth history, although not always. Sometimes there is an event, either prenatal or at birth, that isn't recognized. These patients also have delay and seizures, but the delay, unlike with a lot of leukodystrophies, is static, whereas the leukodystrophies often will have regression. So if you have someone who's regressing or losing milestones, you have to be really concerned about, more concerned about a leukodystrophy. Okay, so here we have a term male neonate, and I think if I just give you that T2 image, this is really hard to figure out what's going on, but it looks like all of the white matter looks abnormal. It's really T2 bright, but also the cortex, right? The cortex does not look normal. It really should be relatively T2 hypointense in comparison, and here it is not. There's also some abnormal signal T2 hyperintensity in the deep gray matter. It looks diffusely swollen. There's a little bit of scalp swelling too. If I show you the diffusion images, this may help. There is diffuse diffusion restriction. Again, these can be difficult to interpret in young children because this process is diffuse, bilateral, symmetric, and they don't look quite the same as an adult diffusion image would be, but this is diffusely involved in terms of diffusion restriction. And then probably the most salient point I could give you is the history. So this was a patient that was born after an abruption, and this is really extensive hypoxic ischemic injury. So we looked at sequela of more chronic injury at birth, and this is kind of what they look like at birth. The patterns are variable, usually again symmetric and diffuse, similar to a leukodystrophy. They typically will affect gray and white matter, both, and there is obviously diffusion restriction, which can be seen to some extent in leukodystrophies, but generally has a different evolution in hypoxic ischemic injury. So sometimes if we're not sure if it's a metabolic disorder or leukodystrophy or birth-related injury, and it's rare that we don't know from the clinical history, but occasionally we don't, we can follow it and make sure that it evolves the way we would expect in ischemic injury too. Okay. Here we have a 5-year-old female with clonus and hyperreflexia. So we definitely have some white matter changes here. There's some speckling in the subcortical regions and in the deep white matter. Posterior predominant, but looks fairly asymmetric, more on the right side definitely. There is some gray matter involvement, caudate, basal ganglia, some changes along that internal capsule as well. So looks a little bit more patchy and certainly much more asymmetric than many of the leukodystrophies that we have seen. And this is actually a patient with ADEM, so this is an acquired inflammatory demyelinating process in contrast to some of the heritable ones that we saw earlier. These patients have patchy changes in the white matter. There's usually gray matter involvement as well, although not always. Bilateral, and it tends to be, again, patchy and asymmetric, whereas the leukodystrophies are really more confluent and symmetric. Often there's a correlating history of recent infection, but not always. Okay, so if we look at these, which of these was a leukodystrophy? Oops. Oh. My animation didn't work. Okay, so this is the leukodystrophy, and which one is it? Well, it's central, right? We have sparing of the subcortical white matter. Doesn't really have so much of an anterior-posterior gradient. This one has less of the conspicuous sort of tigroid or leopard skin appearance, but there is a little bit here. And this actually was a case of metachromatic leukodystrophy. This is the HIE case I showed you, the PVL, and a case of ADEM. So I think in summary, for approaching white matter disease, know your normal myelination, keep a couple landmarks in your head, remember those general gradients, and then know where you can access an atlas or a chart when you run into something like, oh, I don't know if this is really normal or not. Think about the patterns of signal abnormality. So is it hypomyelinating or is it abnormal myelin? Is it central? Is it peripheral? Is it anterior? Is it posterior? Remember to kind of try to distinguish leukodystrophies from other white matter processes. There are a lot of them. The leukodystrophy is, again, confluent and symmetric, is more consistent with the leukodystrophy. And clinical features, you really shouldn't be reading these studies in isolation. It's one of the many times that we really need a lot of clinical input. Do they have cognitive decline? Do they have regression, or is it a static delay? Do they have ataxia and motor signs? Do they have nystagmus visual symptoms? All of those things I think can be helpful. Also, just want to give a shout out to, this was an article actually like 10 years ago now from Schiffman and Vandernap that actually approaches this from an MR pattern standpoint, whereas I think a lot of articles really talk about the underlying metabolic abnormalities and genetic abnormalities, which is, I think, important to know, but honestly, from a radiology standpoint, that's not really how we approach things. So this is really, I think, a very nice article and a chart. If you're going to take, some references home from this, this is a useful one. Gives you, confluent, multifocal, whether it's diffuse, periventricular, frontal, posterior. So this is a kind of nice chart to look at and may help you just think of some potential differentials. Okay, so finally, just to end up with references, Barkovich, the grandfather of pediatric neuroradiology, has a nice article on normal myelination and the overall concepts of that. This is the pattern-based article that I just showed you on the previous slide. This is the classification of leukodystrophies. I didn't read all the way through that. I don't suggest you do either, but it's there if you need it. And then for radiographics, this is an older article, so some of the terms have changed a little bit, but it's a really nice pictorial walk through some of these entities. Okay, and that's me, and that's it.